This paper is really reporting on some of the findings from a larger study looking at the crisis intervention team program in Chicago. And our specific research questions for this paper were to look at what is the impact of CIT response on call outcomes. And our secondary research questions were to look at what is the impact of dispatch coding on call outcomes. So whether a call was dispatch coded as mental health related or not, as well as what is the impact of the location type. So if a call occurred in someone's home versus in a more public setting, and how was that associated with outcomes as well. CIT response did have an impact specifically on the odds that a call would be resolved with a linkage or transport to care. It increased the odds of that. We did not find a significant impact of CIT response on arrest or on informal resolution. Whether or not the call was dispatch coded as mental health related had an impact on all three categories of outcomes, significantly increasing the odds by almost 3 times that a call would be resolved with a linkage or transport to care, and decreasing the odds of arrest or an informal resolution. Call location type also had an impact, with calls that occurred in more public settings being more likely to be resolved informally and less likely to be resolved with a transport or a linkage to care.
Amy and I have been collaborating for probably 12 years now. And, and if I look back when I first entered this space, looking at the intersection between policing and mental health, I think the research and policy focus was very much on how can we ensure that police do a better job, right? So when we discovered that there was a significant issue with people affected by mental illnesses being caught up in the criminal justice system, the obvious place to look was on the police officer decision, right? And really focusing on ways to improve officer knowledge and attitudes and to really help them make better decisions. And that was a critical first starting point. So there's a prior sequence of events. There's somebody in need, either a person or a family or a community, and they are enlisting the police. And so I think we wanted to situate the police in this in a much larger space of multiple decision makers in multiple contexts, that sort of shaping what is possible in terms of what they can do and what other resources are better positioned to handle the issues that police have been called to respond. Together, Amy and I think over the course of our collaborative work have really sought to sort of broaden the lens into the wider environment in which police decision making takes place, and more broadly criminal justice decision making. So the needs of people and families and communities to which police were being called to respond, and trying to understand those sort of in a rich qualitative way, but also mining the data that Amy has collected on the nature of mental health calls that police have responded to really get a deeper understanding of, what's originating these calls to police. What are people wanting and asking? Where are the calls taking place? What are the dispositional options available to police? And what factors are the police facing in their decision-making environments that shape how they decide what to do, right? So the broader decision-making environment. So, I think we broadened the lens, and particularly through this paper have even tried to move more upstream, as other scholars have been doing, such as Cynthia Lum and others, to really sort of look even at prior steps in what Cynthia calls the decision-making pathway, like what got police there. And that's why we've become very interested in the 911 space and the debates around how to reinvent 911, because police are responding to calls because somebody's asked them to go there.
We've trained people to dial 911 when they need mental health care or behavioral health care. Even if you call during business hours, you can't get an urgent appointment. So the recording says, go to the nearest emergency room or dial 911. So if we can create options that are accessible to people before and after a crisis event, then we're going to improve their ability to connect to care before it actually escalates to a really, really bad situation. And I think, part of doing that is making sure that as we build those options, that we go and ask people, what would you like to have available to you to access? Where would we locate it? What type of providers do you want there? So that we make sure that we build options that people will access, instead of saying, I don't want to go over there because I don't trust it. So in the end, things, once it gets really, really bad, they end up with, police or emergency room visit. But I think that is really, that is our best hope of actually really better addressing people's needs and preventing some of the really horrible tragedies that have happened.
Yeah, I agree. We spend too much time doing crisis response, and EDs are crisis response systems, just like police officers are. So any efforts to provide alternatives, like triage centers or the equivalent of urgent care centers, is really important. And underneath that too is there's an important policy, sort of law and policy piece around sort of insurance and affordability of care and access to care. So there's these, underlying vectors of inequality in our laws and policies, right, that may put people in situations where they feel they can only rely on EDs or wait until a situation is so grave that they need to rely on an ED response.
Some of the barriers have to do with just the variation across the board in, how 911 emergency communicators are trained, coding protocols, triaging protocols, and what options are actually available to dispatch.
We, as policing scholars and other scholars and practitioners, even have not paid attention to the call taking and dispatching role, and we've neglected them. Right, we've neglected them as a really important class of professionals who make critical decisions under very stressful conditions, who are underpaid, overworked, and inadequately supported to do the job that we really need and want them to do. So their neglect is a big challenge. And I think now we're finally seeing the tide turning.
I'm particularly interested in looking at some of those triaging decisions. People may call in asking for something, and people may describe what they're seeing differently. So really getting a better understanding of the things that might flag a call for some specific questions. And otherwise, we might develop a protocol that works really well in one community, but it misses half the calls in another community. So getting a better handle on that. I'm also really interested in sort of the development in some of the alternative or additional options for dispatch, and looking at, what do we need in terms of crisis responders if we're not going to send everything to police. And what I've noted quite a bit is that we don't have workforce to actually do some of this work. Even if we're going to focus on existing professionals, we don't have enough of them to do the jobs that we're asking them to do right now. And some of them aren't as interested in shifting to doing this type of work in the community. So I think there's a ton of work that I hope to be part of and do some of the work around it in developing that workforce.
Amy's asking fundamental questions about, what should that first responder look like, or first responders look like? Maybe we haven't thought of them yet, like really challenging our own assumptions about who is best equipped in terms of skill set, in terms of life experience, in terms of community knowledge, in terms of trust and confidence in the people that they serve, who is best positioned to handle mental health related calls or particular types of mental health related calls. So there's a lot of space for innovation, I think, there, if policymakers and practitioners are willing to kind of shed their assumptions about who should be the best first responder. I'm also interested in the, continuing work on the triage decision-making piece. I think many jurisdictions, including Philadelphia, are experimenting with co-response models, and in other types of alternative responses, which is wonderful. And we're at a great time now where jurisdictions are asking these questions about who is best positioned to be first responders. I think too that jurisdictions are open to really answering basic questions around what do people want when they call the police? What do they really want? What do they need? And so we have to ask people, right? So, that this is really stripping back to basics even before the triage, which is going out into communities and understanding what communities want. And as part of that, really trying to understand what might be driving racial and other disparities in call outcomes. Some important work is going on now in that space, or at least asking the question of what's driving those disparities. But I think we're far from having a grip on it. So, what do we do when people call the police who are already sort of trying to enlist the police to respond in a way that's clearly racist? How do we deal with that, right? So again, this is kind of community building work and almost having conversations with communities and building awareness as to how we are all participating in developing systems that become racist and that stay racist because we've sort of created these institutions ourselves. And so those are really sort of daunting and overwhelming questions, and I don't begin to have an answer to them, but I think it all comes back to really understanding the community perspective and really taking seriously the community voice in that, and the dispatcher voice and the call taker voice too. Like, what are they struggling with when these demands are being placed on them? I don't think we've listened enough to dispatchers and call takers either.
We actually do have a ton of opportunities to be innovative and developing new options. I think it's doubly important that we pay attention to race disparities. Otherwise, we're just going to develop systems that further increase them. And that's something I really worry about as we're looking to reduce the role of police in mental health related events. The caveat is always when it's safe to do so. So looking at what do they mean when they say when it's safe to do so? And what are the aspects of safety that we need to prepare responders to handle, so that we don't just end up continuing to send police to some communities and sending some alternative responders to others. It comes in, it's how callers demand things. I think there's bias there. There could be bias in how call takers define the nature of a call. And it doesn't just start with the police officer. There's a whole chain of events. And I think that's why it's really exciting to see more attention kind of moving up the chain. Putting some attention on how we prepare and support emergency communicators in identifying calls that are mental health related, as well as supporting those triage decisions. And I think this points to the need for more research, but also policy attention on that piece of that chain of events. That we're learning that it could be a really important piece, and it's very, very fragmented and inconsistent in terms of kind of what type of training and support 911 communicators actually receive.
I would add too, certainly coming out of this paper, that what we found was that place matters. So, the places and spaces where calls originate, there's something there that we spotted in terms of how that may shape outcomes, as Amy explained when she discussed the results. In a private dwelling or in a family situation, there may be particular sets of needs and a desire for more formalized response, such as linkage to an ED, whereas in other public spaces, we see other decisions being made and requested around how to handle certain situations. So there's much there that links with the literature on environmental criminology and place-based criminology, which is to really understand, what's happening in that time and space moment that's shaping sort of what's being demanded of police and what's available to them. in handling that situation in that time and space moment, because depending on where you are, what place you're in, there's going to be different stakeholders, right? I mean, what families want for a loved one might be different than what a business owner wants for someone who's presenting signs of mental illness outside of their store. Another policy implication is, and this is, folks are really doing important work on this as well, is looking beyond ED. So, you know, in Amy's work, you know, linking folks to EDs is important. But certainly Amy's made clear that we are unclear as to what happens after that initial linkage, right? So on the one hand, we're talking about moving upstream to earlier sequences of things that happen, but we also have to look at the back end too. So it's simply not good enough, right, from a policy perspective to say we've linked somebody to an ED or even to a triage. We need to know what happened to them after. And so there's clear sort of data linkage pieces and working across sectors to share administrative data and really track people's pathways and trajectories and make sure that they're actually ending up on a journey of recovery and not cycling back into more police encounters.